Hello, and welcome to episode 14 of this podcast series from the Staffordshire and Stoke-on-Trent NHS Clinical Commissioning Groups, or CCGs. I'm Richard Caddy, and today I'm talking to Kate Farrow, a nurse and head of urgent operations at the CCGs. Kate has been seconded to the NHS 111 service during the coronavirus crisis.
Hi, Kate.
Hi, Richard.
So, do you want to give me a brief history of your life up to approximately the last week in March 2020?
I've been at the CCG for the last 5 years as head of urgent care, the operational aspect of it. And then at the latter end of 2018, went off on secondment with NHS England to a local acute trust to help run their A&E departments. I was due to return on the 1st of April, and sadly COVID hit us, and I was redeployed, as were most clinical staff, out to another organisation to support the intensity of the national pandemic. So I was given an option, which was great. I could have either gone into testing, or I could have gone back onto the wards, or I could have gone to 111. So I do know the 111 service quite well, but don't have a fantastic understanding of it. So I made the decision to go to 111, completely oblivious as to what would that mean to me. A little bit naive, thought I would just be in a call centre answering calls with all the knowledge that I already have as being a nurse for 26 years.
Going to work in a hospital to support them would have seemed the obvious option, but you were quite happy to go to 111.
I was, because I'd been already seconded out to a hospital for the last 18 months, but I had a real commitment personally that I wanted to support COVID and support our local services with the delivery of care.
And 111 is obviously something which is run from a call centre, it's telephone based. So had you got preconceptions about what that would be like, and how different were the preconceptions and the reality when you got there?
Yeah, and it's interesting you say that, because that's one of the reasons that I wanted to go, because I'd never worked in a call centre, and obviously now in the NHS we have more and more call centres coming on board. So as I said, I thought it'll be easy, I'll just go in there, I've got loads of clinical experience, an A&E nurse by background, somebody's going to call me and I'm going to just be able to give them my advice. It wasn't like that at all. So I went through a really in-depth training programme, and immediately all my preconceptions were put to bed. It is a really intense area to work in. You take a call, the minute you end that call, you don't have an option to get up and have a break or to think or reflect about that call. You go immediately onto another call. So it's a really stressful situation to work in. The call handlers and the clinicians are absolutely fabulous and do an amazing job. Their resilience is unbelievable. The organisation is really, really supportive. They make sure that every hour that each individual takes, a couple of minute break, gets up, has a walk around, gets a fresh drink. So they're really, really supportive, but it is really intense. And I was quite naive to that, to be honest, Richard.
What sort of training's involved?
So initially, even as a clinician, you have to train to be a call handler. So that was a full 2-week full-time training course that you do with one of their experienced call handlers who are trainers. So that's learning about all the pathways that are written, because everything is triage based and everything works on an algorithm. So it's difficult to make a mistake, but it's very easy to go off piste. So you have to stay on track. So there was a 2-week course for that. And then for the following 2 weeks, you work with another experienced call handler being assessed. And at some point during that 2 weeks, you're signed off as competent. And I had about 4 or 5 shifts, was signed off as competent, and then was able to work as a call handler for a couple of weeks. After that, I then had to do another full week's study as the clinical training, and that's more where you learn around how to use the clinical system, how to, if you disagree with what the outcome of the call handler's triage is, which is electronic, as a clinician you can override that and make a more appropriate decision on what's right for the patient. So that again was an intense week, followed by another 2 weeks consolidation with an experienced clinician who then signs you off. So that was 7 weeks in total.
But if you're the experienced clinician working in that call centre, you can use your clinical judgment to override what
Absolutely.
the check
And the pathways support you doing that. So you can go down a different route if you feel, there's a different route clinically that you need to go down. It's all very safe because it is pathway driven and it's still algorithm driven, but you're able to adapt it a little more. And the thing that you're able to do as well is to, as a clinician, build a much better rapport with the patient, because you're able to probe them much more. So as a call handler, you have to stick to the script of the questions. As a clinician, you're able to ask additional questions, which will then lead you down a different route.
Okay, so obviously COVID pandemic came along. What sort of cases were you taking? Were they predominantly COVID, or was it all the other things that come in as well?
So it was probably 50-50, and it was determining whether you thought it was a COVID call, because obviously we've got COVID, but still an 18-month-old might have a rash, might have a temperature, might have a cough. Still normal ailments are still going on, running alongside the pandemic. So I could be on a COVID call 1 minute, the next minute I could have a limp and floppy 6-month-old baby that needs an emergency ambulance, and then I could have a 40-year-old gentleman that's got a dent in his nail. So being able to switch from case to case, as an A&E nurse, I have a lot of experience in doing that, but this was a much quicker pace.
I mean, we all know that working in A&E is an exhausting job because you can't switch off. This seems in many ways pretty similar.
It does, and if I'm totally honest, I feel a little bit sad for the 111 guys, that they've been a little bit lost in COVID, because a lot of publicity is about how wonderful the nurses are on front line, and the doctors and the other therapists, all members of the multidisciplinary team. There hasn't been a lot of publicity around what the 111 guys do, and they really have worked so hard to keep patients at home, really hard. We will only send a patient to hospital or to a GP if we absolutely have to. Particularly the clinicians, we give a huge amount of home management advice or refer to other services. For example, the pharmacists are so underutilised. It was really useful for me to be able to send patients to pharmacists rather than to ED or rather than to a GP.
So I think when 111 started off some years back, it got a bit of a bad rep. It took time to settle in, and at the beginning there was this sort of feeling that because 111 was rather risk averse, they were sending more people to hospital than before. Do you think it's getting the balance right now?
I think it is, and I think what we need to promote more is the awareness of what 111 managed to keep at home. So everybody talks about they've sent this percentage of patients into ED, or the ED guys will feed back to us as commissioners. We've had lots of patients that have come from 111 today, but actually, do they know what hasn't come to them? Do they know what would normally have come to them, and then they've rung 111 and we've kept them at home, we've sent them to a pharmacist, or we've sent them to an alternative service? That's the bit I think that we're missing, and that's the bit where we need to do some better communications out to our local providers to know how good a job 111 are doing.
I've never worked in a call centre. I've seen them on TV. They look like they're pretty tightly packed places. How was a call centre managing to function during coronavirus? Was social distancing possible? Were you wearing masks?
The normal 111 call centre would have desks a metre apart, with a desk and a desk and a desk. So you'd be sat roughly a metre apart with a sort of small eye level screen sat between you, just to protect the sound barrier. The Vocare team made the decision that they were obviously going to do the 2 metre to support the government legislation, and that meant that they lost 50% of their capacity immediately. So we would always sit with an empty desk between us, and we would never sit opposite somebody. It would be at a diagonal. That had a massive impact on the service. Losing 50% of their seated capacity meant that they couldn't have as many staff on duty. They
so you're losing staff. So presumably you're losing staff at a time when the volume of calls is skyrocketing.
Absolutely, and the only solution they had was the majority of experienced clinicians who had more than 6 months experience were able to work from home, and the CCG were very supportive in funding some additional equipment so that they could do that with laptops, etc. But for myself, I wouldn't have been comfortable working from home. I needed to know that I'd got somebody there as a newly qualified pathway license holder, that I could ask somebody for help if I needed it. So sort of my cohort were not able to do that. So at times I would be sat right next to somebody else because I was training. We would always wear masks. We didn't wear gowns, but we would always wear masks. They had a very thorough cleaning process where somebody would clean, the sort of the touch areas in the department every hour. So that took staff off the shop floor and unable to answer calls. But to be honest with you, Richard, it was scary. I drove to work every shift thinking, am I going to get COVID today and bring it back to my family? But the service still had to run.
Because a serious infection outbreak in 111 would have had massive consequences, wouldn't it?
Absolutely, and still would.
Did morale in the 111 service, what was it like? Has it stayed relatively high?
It's like a remote A&E department. They thrive on the buzz and they thrive on the pressure, which surprised me. When sometimes you see the stock exchange on the telly, don't you, and everybody's really very excited and all arms are throwing around. It is like that. The morale was really, really good. Everybody kept each other motivated, and they embraced me as a commissioner really well. I was treated like one of them from the minute I walked through the front door, and that was really lovely. They were just so grateful for all the help, but the morale was amazing. Their resilience is unbelievable. But it is like a remote A&E department, just without the patients. They're just on the end of the phone.
You touched on it very briefly, I think, but over the phone, in the space of a relatively short phone call, can you build a kind of rapport with the patient in the way that you can do if you're treating them in a hospital?
So surprisingly for me, yes, that was one of my preconceptions that I wouldn't be able to, but very quickly I learned how to do that. And it's all the nurses listening to this will know how important building a rapport with your patient is, because you find so much out about how ill they are, what their symptoms are, and how it's affecting them. So being able to build that rapport, asking them what they're doing, have they watched the football the night before, have they been out for a walk, building that rapport is really, really important to be able to make the right recommendation for those patients, because it's important for people to understand in 111 you don't make a diagnosis, you make a recommendation to attend somewhere or to be treated at home, and building that rapport was really, really easy, surprisingly.
And do you get the same satisfaction when the patient realizes that their problem has a solution?
Yeah, and they are so grateful if you can keep them away from an A&E or keep them away from a doctor's surgery. What came online as well whilst I was working there was the ability to be able to book directly into some GP appointments. That was absolutely fabulous. As you can imagine, during COVID, it was really hard to get through to GP surgeries, and for our elderly patients that was really frustrating for them. So quite often we'd be able to book them directly into a clinic appointment, and the relief in their voice was so heartwarming to hear that they'd been able to ring 111, they knew they needed to see a GP, and they knew they'd got an appointment booked there and then.
That things are still there for them, basically. Yeah.
Absolutely, yeah. The one thing that was a little bit frustrating was that to book a COVID test until 119 came online, the majority of it was through doing it over the internet, and that was very difficult for a lot of our elderly population to be able to do, because a lot of them don't have internet or are comfortable to be on the internet. So quite often as well, we would end up booking their tests for them online, which took quite a bit of time as well, and then obviously other patients were waiting, so that was quite frustrating. But since 119 has come on board, that has improved a lot, because they're able to call them rather than do it all online.
So obviously your day job with the clinical commissioning group, the CCG, it's more or less it's office based and it's office hours. Did that change when you went to 111?
Absolutely. I went to, for the first time in absolute years, I worked night shifts. I had the opportunity to work evenings, Saturdays, Sundays. I did a 24-hour rota, really, and that was really good, because it gave me the opportunity to support the 24/7 vision that we have in the NHS, but also to learn that different services operate out of hours than they do in hours. So I was able to understand what services our patients had Monday to Friday 9 till 5, and what they had on a weekend and in an evening. And it is very different, and it is something that we really need to work on to get to the NHS being 24/7. Patients aren't just ill between 9 and 5. They're normally ill at 2 o'clock in the morning or 12 o'clock lunchtime on a Saturday.
So I think one of the recurring themes of our conversations with clinicians has been the experiences the last few weeks. Have they been a learning tool, and will they let us do things differently in the future? And you've already, I think, touched on this, because of your role as a commissioner now. What do you think we ought to take away from the pandemic experience?
So we must not go back to how we were before. We've had the opportunity for some of our clinicians in the CCG to go and gain further experience, further knowledge, and we need to ensure that that is used and all the correct skills are used as well. We mustn't go back to where we are. We must take this opportunity to redesign our services and to use the skills and knowledge of our clinicians that have had the opportunity to be able to go and learn new things. And that's an opportunity I'm really grateful to the CCG for, because I know it was difficult for them to let a number of clinicians go, because obviously it was so busy at the CCG. But we had to A, be supportive of our providers, and B, give us the opportunity as a nurse or a doctor or any other kind of clinician to be able to serve the NHS in a clinical way. That's something I felt really passionate about. How could I be a nurse managing a contract or managing the quality of a service? I needed to be in there helping.
Kate, that's been an absolutely fascinating insight. Thanks a lot.
It was a pleasure.